Valente. I'm at the Arthritis Center of Nebraska, which is just downstairs. Many of you look familiar, so you know where it is. If you have heard me talk about lupus before, unfortunately the story hasn't changed much. It's pretty much the same disease it was last year. Last year it was called the Year of the Wolf, because for the first time in over 30 years a drug was approved for the treatment of lupus. So there was a great deal of awareness about lupus that came from the company that brought the drug to market, and by the Lupus Foundation of America, which tried to publicize and also increase awareness, because it is an exciting time when you've got, first time in over 30 years, a drug has actually been designed to actually help with a disease that otherwise has been somewhat difficult to treat. The word lupus comes from the wolf, and people have argued back and forth as to where that word came from and how it got worked into the term systemic lupus erythematosus. Well, systemic just means it's throughout your body, and erythematosus means red. So it's all through your body, lupus red. So that doesn't make sense either. But some people have suggested that it made the face look lupine, or that it looked like the blue wolf had bit the nose or something. And I guess there's a little, it's awfully little though, I'm not sure I would have come up with that association, but that's where the words came from initially. And we abbreviated SLE because it's awfully hard to remember how to spell erythematosus, to be honest. It ends with a US, and I don't always remember it, but SLE is easy to remember. Systemic lupus erythematosus, but actually it's inflammation, and it comes in a lot of different ways. You can get inflammation of the lining of things, and that's the important part that rheumatologists get involved with. The inflammation of the lining of joints, inflammation of the lining of the lungs, inflammation of the lining of the heart, but it also can cause inflammation of the skin. You can get inflammation of the lining of blood vessels. So this is inflammation of the lining of things and skin. There is two real kinds of lupus. There's skin deep lupus, which we call discoid lupus erythematosus, and there is systemic lupus erythematosus, which is the one that has the arthritis with it. We call it SLE. Women outnumber men 5 to 1, and I think that's probably generous. I see probably 10 to 1 women with lupus. It starts young. I mean, you can have pediatric lupus, usually in the youthful teens. Typically by the age of 40, lupus has manifest, although I had a 92-year-old man who presented with his first lupus, and I really didn't believe he had lupus. It took me an awful long time to appreciate that you can get, as a man, lupus at the first time at age 92, but he did. When we think about lupus, we may know people that have lupus, or we might have lupus, you might have lupus yourself, and you are a very unique group, because lupus is rare, actually. It's about 1 in 1,000 white women have lupus. Only 297,000 women in the country are thought to have lupus, not even 300,000 women. When we think about that common, how does it compare to rheumatoid arthritis? Over 3.5 million people have rheumatoid arthritis. It's more than 10 times less common than rheumatoid arthritis, so it's not very common. And when people usually present to me with lupus, they usually have arthritis. More than half of them will. Most of them will tell me they're sun sensitive. Most of them will have, well, many of them will have a rash, but not all. If the sun was out, they'll have a rash. Only about 5% of them have involvement of the kidney. Some will have some fever, and others will have inflammation of those other things, blood vessels, lining of the heart, lining of the lung, or even unusual things like seizures or blood clots. So the most common presentation is arthritis, rash, sun sensitivity. That's what we usually see people presenting with lupus with. Although they can have those other things, those are by far the most common ways that they present. What causes lupus? Lupus is the classic autoimmune disease. What do we mean by autoimmune? That means that our body's own immune system doesn't recognize us and starts fighting us by beating up on our different parts of our body. We end up developing antibodies to things that are part of how our cells work. We get antibodies to the nuclear components inside the cell, like the DNA. And we have no idea why the body does that. It clearly, somehow, the control of the immune system is lost. And we start developing antibodies against cellular components, part of us. And when this inflammation develops, it consumes some of the natural anti-inflammatory proteins in our body called complement. And complement is part of, it's like fuel to the fire, and the inflammatory process grows, not just from antibodies that deposit on the lining of things, like the lining of blood vessels, or the lining in the joints, or the lining in the kidney, but then it recruits these other chemicals in our body that are part of the inflammatory and anti-inflammatory cascade to produce quite a bit of inflammation. It can be made worse with sun exposures, and that's not all understandable why that happens. It's clearly made worse when people smoke. There's clear gender influence. We're going to talk about how that's inherited in a little bit. And we see less of it in whites. We see more of it in people who are poor. We see more in blacks. And we see, for some reason, more in Asians. We see a lot more lupus in Asians. And for some reason, red-headed folks from Ireland. So it's not clear exactly what the genetics are, but they're clearly strong familial associations. If you have identical twins and one gets lupus, you have a 50% chance that the other gets lupus. So the closer you are genetically to someone who has lupus, the more likely you are to get it. But if you have fraternal twins, they're not identical twins. Then the risk, if you get lupus, the other one gets lupus, is only 5%. So there's a very strong genetic component that falls off quickly if you're not identical. It can occur with other autoimmunity. So we see a lot of folks with lupus who also have thyroid disease or things like hemolytic anemia or something called immune thrombocytopenic purpura. And you also see it in families that have rheumatoid arthritis, scleroderma, or even diabetes. So there seems to be this trend of autoimmunity, and it doesn't always have to be the lupus that ends up being found in the families. In fact, some people have estimated that diseases like lupus occur in women, so that about 1 in 20 women will have some form of autoimmunity. So this is really, it's not lupus that's common, but some form of autoimmunity. Thyroid disease, hemolytic anemia, diabetes. About 1 in 20 women will have some form of autoimmunity. When we ask, though, did your mom or dad or brother or sister have lupus, it becomes clear that most people that end up seeing us don't have a strong family history. It just occurred spontaneously. Now, the lupus skin rash comes in a couple different flavors too. It can be either skin deep or include the internal organs like the joints and the lungs and that sort of thing. But the skin lesions can be scarring, very thick and inflammatory. Like these lesions are on the cheeks, which will leave scars, or in the scalp where they won't grow hair anymore. On the dorsum of the skin, on the dorsum of the hands, it almost looks like it's psoriasis there with a scaly top to it. And other times the rash is not quite so severe, or while it's all over the body, we'll have more of this what we call annular polycentric. It looks like little circles of redness, almost like ringworm, isn't it? But it's not. It's much more inflammatory than that. Or it can be just something that's set off by the sun. Or it can just be an area where you don't grow hair anymore, called alopecia areata. And sometimes that can be associated with inflammation and that really thick, scarring discoid lesions, or it can just be no inflammation at all. It's just that the hair follicles are gone. And then the sun sensitivity with the malar rash. The sun sensitivity is not something to make fun of. Folks with lupus may not get much sun up here in the Midwest, and then they go somewhere for vacation, and they say, well, I don't burn, or I don't have a problem, and the doctor told me to use sunblock, and I didn't pay attention because it's never been a problem. They go to Jamaica or Mexico or something, and they come back, and I bet it's 2 or 3 times a year someone will come back with just a god-awful rash all over their body because that's a different sun down there, and you got to use sunblock. We had one lady who just didn't put the sunblock in between her breasts right here. She put it everywhere else, but she forgot to put it there, and the bathing suit opened there. And she got huge sunburn just right there, and within a week, she was covered with that subacute cutaneous lupus erythematosus, and it took about 6 months to get that calmed down. The lupus can also produce rash or arthritis, and the arthritis can sometimes be pretty subtle. If you look, these knuckles across the middle of the middle knuckles here are swollen, and that's the favorite joints for lupus arthritis. It's those middle knuckles. So I'm always looking there for the arthritis. The other thing you notice about lupus arthritis, it's symmetric. So if it's on one side of the body, it's on the other. So it's a small joint, symmetric inflammatory arthritis. Sometimes it's quite a bit more than just these knuckles. These knuckles can get swollen too. The wrist can get swollen. You get that kind of a puffy, pillow-looking hand. And sometimes it's associated with rash. And the rash will come along the nail folds around the nail, and between the knuckles you'll get this kind of red banding. And it's not discoid, it's not subacute cutaneous, it's just a redness from the lupus rash. And then when the arthritis has been present for years and hasn't been well controlled, you can see deformity. And the deformity is special because you get these kind of crooked looking smaller joints, and you get this ulnar drift to the fingers, so the fingers curve out towards this side of the arm. And yet when you get x-rays of it, the bones and the joints aren't destroyed. It's just that they're kind of like falling off their hinges. And that's called a Jacquard's arthropathy. It's because the inflammation causes ligament laxity, so the joints aren't supported anymore in the right way. So the bones don't get destroyed, the cartilage doesn't get eaten up like it does in rheumatoid, but you get deformity just the same, and loss of function because the joints don't line up well. You can get inflammation of the eyeball, and it's usually the lining of the eyeball, like the white part there where it gets all inflamed. Sometimes that inflammation will go through and through the whole eyeball. And if that's the case, that's a life threat or eyeball-threatening disease. You can end up having so much inflammation that the eyeball would pop or rupture. So that when we see that, and I've seen it only twice in 12 years, you have to use chemotherapy to control that inflammation so they don't lose their eyes. Sometimes it's just simply dry eyes. In fact, about 20 to 30% of folks with lupus will have dry eyes, and they have to use artificial tears or other special medicines to keep the eyes from drying out. And then rarely on the back of the eye, when you look in there, you'll see the tiny blood vessels on the back of the eye will become blocked, and they'll hemorrhage. Or they'll leave a little white spot called the cytoid body. And that means that the circulation to the back of the eye is being compromised because of the inflammation in the lining of the blood vessels there. That's a marker where, when you see that, you have to worry that the lupus has gotten into the brain. And only about 2% of lupus patients have lupus in the brain, and that's not a good thing. Thank goodness it's rare. You can get lining of the mouth and lining of like we call it mucous membranes, the stuff that's wet, you know. But the mouth is the good example of that. You can get ulcers, you can get blisters, you can get a real dry mouth from having inflammation of the spic glands so that they aren't able to make saliva. And the mouth, when you look at it when it's dry, there's no question, that person's got a dry mouth. It looks like the Sahara Desert in there. They lift up their tongue, there's no saliva that pools on the bottom of the tongue. That's a really, really dry mouth. Thank God that's also pretty uncommon, but ulcers are real common. And about a quarter of the folks who have lupus will get ulcers on the inside of their nose. So we always look for that. One of the problems that happens in a lot of different arthritis conditions is called Raynaud's. Now, lots of folks have fingers that get purple when they're cold. That's called acrocyanosis. But if it's accompanied with white attacks, where the distal fingertips get white so that all the blood's just scared right out of their fingers like a ghost, when that happens, that's called Raynaud's, and that's part of, if you have the white attacks, that's complete Raynaud's. And that's a bigger problem for a lot of folks as they get older. Sometimes the blood vessels become hardened or thickened and they don't have good blood supply. You can get ulcers on your fingertips. But most of the time, we can manage that by avoiding the cold, avoiding caffeine, and keeping all bundled up in the summertime or in the wintertime.
Why caffeine?
Caffeine causes vascular constriction. That's one of the ways we deal with migraine headaches is that, aspirin plus caffeine is better than aspirin alone because it causes vasoconstriction. You don't get the vasodilatation, which we think is related to having the pounding part of the migraine. Constricts the blood vessels. The blood vessels can get constricted in the skin of our forearms. We get this little lacy-looking thing called livido, but it can get so severe that the blood vessel closes off, and the distal tip of the fingertip could lose some substance because it's not getting a good blood supply anymore. Or larger blood vessels can be involved, and so whole areas of skin can become damaged from not having good blood supply. Toe could be lost because of that. That's called vasculitis, inflammation of the lining of the blood vessels. And in some cases, it'll affect the nerves that get fed by the blood vessels, so they'll get numb or weak in one arm or one leg. That's called a mononeuritis. So sometimes the vasculitis can be life-threatening or at least limb-threatening, and it's pretty scary. And again, thank goodness, that's uncommon. But you can see that lupus starts to look like so many different things: rashes, arthritis, inflammation of the lining of heart and lungs, blood vessel damage. That's why they start to call it the great mimicker. That's why on the TV show House, every time they have a person who's sick, somebody says, that must be lupus. And then he always says, what? What does he always say? It's never lupus, right? Not quite. There's 300,000 women with lupus. But if you were a betting guy, you wouldn't think that it was lupus. And sometimes on the show it actually is lupus, so that's kind of silly. But that's become the running joke on that show, by the way. Obviously, a rheumatologist wrote at least one of those episodes. If you have skin-deep lupus, you only have about a 10% chance over a lifetime to get lupus that's going to be systemic. And there are some predictors of that, depending on what kind of blood tests you have. Usually your blood tests are normal with skin-deep lupus. But whether it's skin-deep lupus or it is systemic lupus, the skin lesions in lupus respond to stopping smoking, avoiding the sun. That doesn't mean just not going out and tanning. That means wearing a sunblock all the time, winter, summer. That means wearing a big floppy brimmed hat when it's summertime. That means blousy long sleeve shirts that have the SPF built into the fabric. That means a pretty good job of avoiding the sun. Sometimes the skin doctors, the dermatologists, will give us topical therapies like steroids or something called Ilodel, which is a cyclosporin, a very expensive cream that's very anti-inflammatory that can be helpful. We treat from the mouth side. We use anti-malarial therapies like hydroxychloroquine or quinacrine for the skin, and that works very well. A number of studies recently have shown how effective methotrexate is in the skin lesions of lupus. Then if those things don't work, azathioprine and thalidomide are choices. And you may remember the word thalidomide, right? That was for the little babies that were born with the short little arms, cyclomelia. And we don't have that drug in this country available to just anyone. You have to go through a whole lot of hoops to become registered to give that drug, and then we have to watch people very carefully because of previous problems. But at least in the last 10 years or so, the drug has actually been available in the United States, and it turns out it is essential for a very small group of people. Nothing else works for their lupus and their skin inflammation. Amazingly so. What about the internal organ arthritis? Well, anti-malarial therapy has been the mainstay for as long as you can think back about lupus. The anti-malarials that we use were invented in the mid-40s to compensate for malaria that was becoming resistant to quinine in the Pacific Theater at the end of and right after World War II. The Army doctors there were treating young GIs with these drugs for months at a time to prevent malaria. That's the only way they would have figured this out, because the drug takes 3 months to start to work in lupus, and they found that the young men, and 1% of all young men have rheumatoid arthritis. So this is where it was first noticed. This drug, anti-malarial drug called hydroxychloroquine, actually made a difference in their inflammatory arthritis. It was a wonderful observation on the part of those doctors, and it didn't take long, probably about 15 years, for this to become much more popular in the treatment of all sorts of inflammatory arthritis. And ultimately, the anti-malarial drug has now become the mainstay of therapy for the treatment of lupus. If you have lupus, you're on hydroxychloroquine, unless you have an allergy to it or some other reason why you shouldn't be on it. Once lupus, always hydroxychloroquine, because it kind of become the rule. And the reason is people do better. If you take people who are well controlled on lupus and they've had hydroxychloroquine for 6 months to 3 years, and you take away the hydroxychloroquine because they're feeling good, they're 6 times more likely to flare with a life-threatening internal organ involvement with lupus in the next year than if you leave the people on the hydroxychloroquine. So it's an insurance policy, basically. It's amazing. And it's only in the last 2 years or 3 years that we figured out how it even works. And that's really complex, and we won't get into that today. Aspirin-type drugs are also popular just because they do help with inflammation. The ibuprofen and naproxen have taken over for aspirin because they're generally better tolerated. You don't get a lot of ringing in your ears, maybe less ulcers, that's an argument. Prednisone is FDA approved for the treatment of lupus, and really for years and years and years, the people who had moderate lupus will live on 10 to 20 milligrams of prednisone a day. We've gotten a little bit away from that idea since I first started as a rheumatologist in the 1980s. I don't see as many people on 10 or 20 milligrams of prednisone for decades. This was just devastating for the lupus population because it stole calcium from the bones, it made their muscles weaker, gave them big round faces and bellies, and cataracts and diabetes and thin bone and osteoporosis, premature heart disease, and all those other things. And it turns out now we know that prednisone is the most dangerous drug we can use in rheumatology. Just 5 milligrams a day doubles your risk for infection. 10 milligrams a day quadruples your risk of infection. So whatever your risk was, it's 4 times as high. There's no other drug I have in rheumatology that potent in suppressing the immune response. And so we want to get away from prednisone, and so a whole host of other drugs through here have been suggested as steroid-sparing drugs. Azathioprine and methotrexate are the most commonly used. In the last decade, a drug called mycophenolate mofetil, or Cellcept, has come out, initially only for lupus and nephritis, kidney disease, and it looks like it's a very good drug for kidney disease. It's now being used in lupus lung problems, and sometimes in the skin disease. I'm not impressed with skin and joint help with this drug, but certainly it has a role to play in the brain lupus, the kidney lupus, and the kidney lupus. That's about it. Cyclophosphamide is a really potent chemotherapy drug, and when people would get so sick with lupus that their hearts or their lungs or their kidneys or their brain was being threatened, we almost always turn to